And all right, thank you. Thanks. Okay, I'm going to call to meeting this order of the Assembly Housing and Homeless Committee. It's January 21st at 11 a.m. Let's first start. Looks like we have two members on the phone. Ms. Baldwin-Day, are you there?
I am, and I will be there in person shortly.
Wonderful. And Ms. Silvers, are you there?
Yep, Yara Silver is here.
Okay, and this is Cameron Perez-Verdia. We have other members, I think, that are going to arrive in a bit, but we should get started. For those on the phone, if you want to get into the queue, please send me a text. And let's see. I think we're going to start with RRS, right? Are you guys here? Yep. Come on up. Yeah, I think you guys can all come up. I think that's smart. Team effort. All right. And let's see here. Okay. All right. Let's get started. If you'd introduce yourself for the record, you can begin.
My name is Kathleen McLaughlin. I am with Restorative and Reentry Services, RRS, that has third-party oversight contract with the.
And Emily Robinson, and I'm also with RRS.
So briefly, within the last month, we have had a lot of activity in the shelter system. It has 450 shelter beds. We also had Anchorage Safety Center have some overflow beds so that we can.
Oh, sorry. Is your mic?
Point of information. I can't hear. If she could turn her mic on or speak into it.
Yeah.
Test. No, that one's not.
No, it's not working.
This one.
Thanks
Okay.
for letting us know.
Thank you. So within the past 3.5 weeks, we've been using the 450 shelter beds fairly efficiently. We are trying to remain full every single night in order to make sure that we are using each one of those in the best way possible. That has required us to shuffle people around and to put people in these spots in which they are most likely to be able to self-manage. So that I think has been the shelter program at that level has been very stable. During the super cold weather, we were allowed to expand the Anchorage Safety Center so that we could have more of a warming, an overflow is I think what we called it at the transit center. There were 25 beds there that were used almost every night. I shouldn't say beds, they were cots and a place for people to warm up. The Anchorage Safety Center was also running at about 30 people per night at its main location. I'm trying to figure out when was
It was from, and Ben's going to give like an overview of,
Oh,
the,
okay.
of the overflow, so I think you can focus on shelter.
One of the I think greatest benefits was Beans Cafe also became a day warming center. They're a nonprofit that could do that at their location at the Children's Lunchbox. So individuals that couldn't use 3rd Avenue navigation were also able to be at Beans in order to make sure that they were staying warm and had someplace to go when 3rd Avenue navigation wasn't there. So as far as the linkage between people that were on the street coming in and then using and being folded into shelter, I think the program has worked as efficiently as possible. We didn't have a lot of critical incidences. We do see some drugs coming in to the shelters. We have proactively looked into that, especially at the Alex Hotel, in order to make sure that that is a safe place for people to go. And we have terminated people using that program because of drug usage or drug distribution. As far as the other shelters, I think they are being efficiently run. We are auditing the beds right now in order to make sure that the people that are using the beds are either moving forward because they have plans so we can get them on an outflow of the shelters, and also trying to figure out which individuals need higher levels of service. We have had some move into assisted living, and we have had others that have gone to the hospital waiting for assisted living beds. So I think in general, the linkage has been positive, and although we will never be done with perfecting this, the system is working as best as it can right now. Did you want to add anything? Oops.
Just for the record.
Yeah.
Hold on one second. Does this work? Oh, just for the record, Mr. Johnson has joined us on the phone.
I just wanted to add about the evening shifting and efficiencies. When we were in that really cold snap, we also had 8 additional spaces at each of the shelters in the warming waiting area. And so what that looked like is we would start sending people at 56. It was for congregate only, so 56 in Linda's place, who would be waiting for bunk flips to occur. So once bunk flips did occur at each of those locations, we were able to fold people in directly from the waiting warming area, which opened up capacity in the waiting warming area, which then we could decompress the safety center in real time. So once the safety center started getting higher on its capacity and around 1 or 2 in the morning, we were able to decompress that site and put them into the shelters. And so we were able to kind of just 24 hours be shifting people so that we could accommodate as many as we possibly could.
I guess part of what I'm curious about is that it's, I mean, it sounds like an incredible logistics challenge of in all of this. I mean, are people being left out? I mean, that's the I guess the question is, at the end of the day, did we have to not allow people to come inside? Is there always a place for someone to go?
The answer is yes. And the reason that this happens is because when we get a call from anyone, we can direct them to at least a warming area or a place to wait for a bed that's inside. Many of the people that do not want to still come inside, it's because they are still steeped in activities on the street that don't allow them to stay inside very long, or if at all. And that population we aren't serving in the shelters very often because they do not want to partner with us. So there are individuals that are on the street or not using shelter, and those we cannot count as not being able to have a shelter bed because they don't want a shelter bed. One of the things that we do is when Emily and I get calls from individuals, we don't say, you're going to get turned away. It's, this is how we're going to find a path for you. For people that can self-manage, we have decompressed by using good neighbor funds at some of the smaller hotels, and we have brought people from the shelter into those smaller hotels that have been great partners. And by doing that, we can get them out into a place to be able to launch and open up a shelter bed. The other thing that's been really interesting recently is there must have been some TV program that related to Alaska and how extraordinarily rich you can get when you come up here to work. And so we've had several people who have come up here on a whim, and we are using good neighbor funds to allow them to realize that they may want to go back to where they came from. We're seeing a trend in that. So we're not letting people just get folded into the shelter if they really shouldn't be here in the first place.
Yeah. Okay. I have a question for you, Ms. Baldwin.
Yeah, sorry, it took me a minute to get off mute. I really appreciate the flexibility that's happening in the system right now. I'm curious, like Mr. Presbydia, about the logistics of this. As I understand it, we don't have dedicated transportation all the time. And so how exactly are we moving people among shelters? Are we expecting shelter operators to do that in addition to their existing contracts? Are we expecting them to use personal vehicles to do that? I mean, what does that actually look like in practicality?
Thank you for the question through the chair. We've been patching together a smish smash of different resources. So depending on the availability of the shelter operators, the Anchorage Safety Center dispatch, and other taxi vouchers through Good Neighbor Funds, we use a few different resources. So on any given night, sometimes the Safety Center will be decompressing their site and bringing people straight to shelters. In other occasions, depending on availability and timing, again, the shelter operators will go and pick people up. And then if all else fails, we have taxi vouchers that we give, and they can send up to 2 to 3 people at a time.
And
So we
this
are
is
expecting
the,
shelter operators to provide transportation?
Can I just add to that, through the chair? This is the Agnew Benben, Special Assistant to the Mayor. So it is part of the shelter operator's contract to provide transportation, but as you're mentioning, Member Baldwin Day, it's sometimes difficult to meet the needs. So we have been looking into, Kim Rash, the Health Department Director, and I have been looking into some possible other options, because sometimes we find people have medical needs or disability status that makes it hard to transport. And then there's also just the logistics late at night, the middle of the night, over the weekend. We have gaps. So we are looking into some creative ways to help meet those needs. So we'll be bringing that to you as soon as we have something to share.
Excellent. That's great news. I had a related concern about that, just understanding that shelter licensing requires a certain ratio of staff to clients. If we are asking folks to, number one, absorb additional warming clients over and above their 200-person limit, that by definition requires an additional staff person to meet that ratio. And then if we're also asking shelter operators to provide transportation, we're further impacting their staffing. I'm wondering if we're compensating our shelter operators for having to bring in those additional staff people when that wasn't actually part of that initial contract.
Through the chair, this is Thea again. So when we were negotiating these contracts, those requirements are still part of the contract, in addition to other ones such as having behavioral health, clinical support, EMT. So it is up to the operator to figure out how, within the amount that they've agreed to in their contract, which is a per person per day dollar figure, that they are able to meet the requirements of the contract. And so I think our operators are doing that to the best of their abilities. But then, as I mentioned, there still are gaps. So it's not always that they're using one of their floor staff to drive somebody somewhere. It's like, as Kathleen mentioned, it's vouchers, bus passes, sometimes a driver, sometimes safety patrol, sometimes MCT. I mean, we get as creative as we can.
Sure, but I guess my concern is, are those 8 additional bodies in warming, are those also counted as clients
Sorry.
that
I
are
forgot to
billed
speak to
for?
So that was,
Oh, okay, go ahead.
that was the health department allowed them to do the waiting room with 8 clients, did not require it. So that was something that they were able to do.
Sure, but I mean, I'm just imagining that in a situation where somebody needs to get warm, I can't imagine that any of our shelter operators would be like, no, we're not gonna take people for warming. I mean, I realize that in technically speaking, maybe it wasn't required, but I can also see how it might feel like a lot of pressure to say yes to that kind of a request. And
So,
I'm curious, if they say yes, is there additional compensation attached?
yeah, just from kind of a global point of view. So I think last summer and fall, and as the mayor was putting together her budget, we worked very hard to not increase the spend for these safety net services. So we presented to you a budget that was actually a slight decrement from what we spent in the previous year to provide this kind of crisis care and safety net shelter service. However, yeah, like when you say, is there a place for everybody to go to be warm? No, right? Are the shelter providers getting paid, as much as we would love to pay them to do their work? No. So that is where if this body and the administration wants to make different budgetary decisions, we can do lots of other things. We're being as creative as we can with finding money in different places that we can deploy for these uses, because I think we all have the same goal. But that's the constraint that we're working within.
Yeah, I really appreciate that. I think part of my concern here is not just that we're meeting the community need, but that we are also being good partners to our contractors. And so I think that's sort of the genesis of my line of questioning is, recognizing that we want to continue to have really positive relationships with the folks who are providing services, and and maybe that is a question of appropriation that we need to take up as a body is, how do we ensure that the people who are doing this really important work are compensated appropriately for their flexibility, for, providing on the fly additional services, other duties as assigned. Because I think that will be, on the long haul, really critical for us to continue to have this year-round, really robust, really flexible system. We're going to have to pay for it. So I think I'm curious to hear, what that looks like in practicality, and, are there tweaks that we can make now, like transportation? And then, how can we continue to have a really positive conversation with providers to ensure that they're also feeling good about how the system is operating?
Could I respond just real quick? Emily and I are on boots on the ground every single day. And I was at Linda's place 5 times probably last week. And each time the 8 individuals that are in warming, they are right next to the initial front desk staff. That's where they're at. They don't go anywhere else. And so there is no need for additional staff to oversee this group of 8 that come and go. There just isn't. And because some of them are waiting for beds and trying to comply with the rules, they're self-managing. So the number of incidences are very, very low. So I can just speak just directly, there is no cost to having 8 people sit in chairs in this entryway. There's no cost, there's no loss of anything to the shelter operator.
So shelter operators aren't required to bring in an additional staff person to meet that 50-to-1 ratio if they have 8 people in warming over, and if they're at, say, 200 capacity and then they're at 208.
Well, Linda's
That
place is,
doesn't-
I'm sorry. Linda's place is always overstaffed.
Okay.
So they always have extra staff
Gotcha.
because that's their model.
Okay.
So I guess what I'm saying is they already had those individuals there, and they already had a place for people that would not interfere with the operations of the shelter. But I think the questions that you're raising are good ones to look at as we move forward.
Okay. Yeah, I think I was doing the mental math to say, okay, if East 56 has 200 people and then they're required to maintain a 50-to-1 staffing ratio, do those 8 people in warming bump them up into a place where now they actually need to have 5 floor staff in order to be able to satisfy the requirements of licensure? And if that's not the case, or I guess is that the case then, that they would need, if they had 8 people in warming, they would need to bring on an additional staff person to meet that threshold?
Through the chair. Can you hear me?
No.
Through the chair? No? Maybe.
This seems to be the only good one.
This one works. Through the chair. Can you hear me? Yeah. All right. Kimberly Rash, Anchorage Health Department. So for shelter licensing, you are correct. It's 1 to 50, 1 to 30 at night. And so if the individuals within the shelter are at that level, then yes, they need to staff to that level in order to meet licensure.
Thank you for
Sorry,
indulging me.
1:30 during the day, 1:50 at night.
Thank you for indulging my questions.
Thanks. I think we're going to move on. I did want to just, and we definitely, our mics are pretty low. I don't know if we can turn up the volume on them, but they don't seem to be very, very high. I guess just going back to the original question and the comment about resources and about beds. And I guess that the challenge I have in sometimes in these conversations is the questions aren't necessarily, are we working hard enough or are we doing enough? But the question is, have we allocated the right amount of resources to it so that we have a sufficient number of beds rather than we're doing the best with the number of beds that we have, right? And so that's partly what I'm trying to figure out is that if there are not spaces for the number of people that need the spaces, that's information we definitely need. Because we need to go back and go, okay, then we need to figure out how to make sure there's the adequate number of spaces. I understand it's fluid and it's a very difficult thing to manage, but I think that's why the question comes is are we under-resourcing this right now? Are we under-resourcing the partners that we have? From our perspective, we're thinking about it from a policy perspective, from a funding perspective. That's where the questions are coming from. So,
And I think this is the first year that we're doing year-round shelter at this level.
right.
And that we, made the choices that we made in the fall when we brought the budget to you. And so, I mean, I would say literally every day we're having this conversation of like, where are we at? Like right now, for example, we're under an emergency authorization to have 200 people at East 56. Pretty much every day we're talking about, when are we going to decompress those 50 beds and how? Like, where will we, like, how will we absorb those folks? How many people can we get, out to assisted living? How many people can we move, out into housing? How can we get some treatment providers in there to see who wants to go to treatment? So we're doing that work all the time in order for us to have a good answer to the question that you're asking, because the key factors there are, one, any resources we put towards the emergency room, which is what shelter is, are not resources that we're putting towards, new housing, new micro units, new treatment, all the things. So that's one factor. And then I think the other factor is what Kathleen was speaking to earlier, which is we still have a group of folks that we can't accommodate in our shelter system as it is. So what are the resources we need that would be more acceptable to that group of people? And so that, and I'll share some of those ideas in the dashboard discussion in a little bit, but that's the really tough nut to crack. And so we would love to say, yeah, if we had, 100 more beds, all the folks that have been, using the extended hours at Beans would be in shelter. Well, actually, we don't think they would be. So that's not the right answer. There's a different answer, but we don't quite have it yet.
That's actually really helpful, and it's really helpful to continue to remind us and the community that there are people still living outside in part A, because that's what they're choosing to do, and B, because we don't have necessarily the right setup for them. I think there's likely a combination of that, and that's something that we're trying to figure out. So, okay, thanks. Yes, Ms. Baldwin.
So if we were to look at the turnaway lists that shelter operators are required to maintain, would we see, I mean, is there on those lists, is there a reason stipulated for why they were turned away? And how do we, I guess I'm curious, how do we parse people who are turned away because they have been 86'd from shelter for behavior or drug use or whatever, versus people who are turned away because there's not functional capacity in the system? Like, how do we know the difference on those turnaway lists?
Through the chair, that's a great question. We've been actually working on creating documentation to be able to start tracking this more effectively. I actually get to ask all the turnaway lists. And what we see, the information that we're gathering is the name of the person, the reason for the turnaway, and what the referral and transportation was on the back end of that. And what I see a lot of the times is most people are able to be actually folded in because they go in and they're a waiting, warming person, and then they get folded into a bed at bunk flip time. But the people who get turned away get referred to ASC or open. But then for those pocket of people that can't access shelter, they've now filtered down to being the reoccurring shelter clients at the safety center. That's where they are. And so we see those names because that's the only place they can be right now.
Is that information recorded in HMIS?
Turnaways are recorded in HMIS, or bans are recorded in HMIS. The turnaway list that I'm referring to is not on HMIS, but they are asked to document it, especially if they're already in HMIS.
So how would okay, that's a whole nother rabbit hole, never mind.
Yes, okay, I understand.
And just through the chair, when we get to the data presentation, we'll speak to the big question you're asking, which is how the heck do we know any of this stuff? So I'm going to speak to that.
Yeah, okay, great. Thank you. Thank you for your update. Let's move on to the Anchorage Safety Center overflow conversation. Thanks.
This one work? Sounds like it. All right. Ben Lewis, Assistant Chief, Anchorage Fire Department. As a reminder, the Anchorage Fire Department manages the Anchorage Safety Patrol and Anchorage Safety Center contract, and in a very short time frame. And I think in this example of really good partnerships between intermunicipal agencies and our contractor, we were able to stand up the warming shelter, which was at the transit center in a very short time frame. I think we initiated the idea on Christmas Eve, maybe, if I remember right, and we were able to stand up by December 29th. It was in service for 17 total days. Its last night of operations was January 14th. It was in service from 8 p.m. to 8 a.m. It was at full capacity, which was 25 every night it was in service. This, I think it created some frustrations with the facilities at the transit center, I think, just based on the clientele that kind of hung around after hours and before hours. However, as like a successful, safe place for people to go, it was by all means a very successful place. I can speak to what my own worldview is. I also manage our dispatch center. Every morning during that really cold snap from that time frame that I just referred to, I checked in with the lead dispatcher and asked if there's anyone that called access through either 311 or the 911 system that we were not able to provide an answer to, like a place to go. And the answer every morning was no. We always had a place for someone to go that accessed through 911 or 311 during that cold spell. Leave anything else? Any questions about it?
Yeah, I have a question. So you said it shut down. So can you give us that? So it ramped up to accommodating more individuals than normal and can function as a warming center. And it ramped down on the 14th because it was no longer necessary. What was the reason that?
Yeah, the cold spell kind of snapped and it warmed up was the primary reason. It wasn't like, I think it's kind of always dangerously cold out in the winter in Alaska, but that extreme cold of sub-zero freezing temperatures at night, that snapped right around that time. I don't know. You have anything else you want to add to that, Thea?
This is Thea. So the trigger really for both when we added like the last increment of emergency beds at East 56th, and then also when we decided that we needed to do an overflow space for the safety center is when the safety center was kind of maxing out. And so we had a couple nights where they were just really, really full. And when it's that cold, you can't really humanely say, okay, you two folks are going to have to go outside now so that we can take in someone that APD is bringing to us. So that was the trigger for the overflow. And so then when the safety center started to have more capacity and the temperatures were warming up, that was why we were able to close it. And again, we're really shepherding the resource here. So if we want to have a bigger conversation about budget at some point, we can totally do that. But we did put in a certain amount of money for surge beds in our 2026 budget. But we're assuming that that's for both spring and fall of 2026. So again, we're just trying to be very mindful of the funding.
Ms. Baldwin, did you have a question?
Yeah, I do. So seeing as winter is not even close to over, will the future trigger for potentially utilizing that same space, doing overflow at the transit center? Will the trigger be the temperature? Is that the metric that we'll use to decide whether or not that's an appropriate intervention to repeat?
Through the chair, I think operationally that's one factor, but I think we do really monitor the safety center because we have a responsibility to always have a place for first responders to bring someone. So if that gets to a point where we can't take folks in, then that's when we know we're really kind of at capacity. And we're always moving people. So the reason the safety center is helpful is it's 24/7. So, even in the middle of the night when a bed comes open at Linda's place, for example, we're moving people into that bed. So it's a really good staging area for people. It's not a place for people to stay day in, day out. There aren't meals there, for example, but it's a good sort of triage location that is staffed and indoors and also very low barrier.
So
Can I add one more? Oh, I'm sorry. I
Go ahead. No,
apologize.
please.
I was just going to mention as well that during that, the cold snap is a good predictor of what the stress on the system is going to be. All three major hospitals in Anchorage were all basically on recovery periods during this whole time because they were at capacity of people in their waiting areas and fulfilling beds in their space. Providence even stood up a warming area, which was basically at capacity every night. The call volume, I can't speak to APD, but I'm sure it's the same at Anchorage Fire Department was about as busy as we ever see, including calls in our dispatch center and calls for service. And that all peaked out during those really cold temperatures. And as soon as those cold temperatures warmed up a little bit, they've all pulled back. And I interrupted you, I apologize.
No, I appreciate the additional information. So were we staffing that overflow? Better question, who was staffing that overflow?
Through the chair, it was the contractor, Sala, who operates the safety center, basically treated it as an extension of the safety center. So they use their staff to staff it.
Okay, I don't see any other questions. Thanks for the update. And now we're going to move on to outreach update. Welcome.
How we doing today? So a couple things to just touch on for the Anchorage Police Department.
Can you just introduce yourself for the record?
Alex,
Thanks.
so we have we've been working on something for a while now.
Playing shuffle the microphones today. So one of the great things that we're doing is in an effort to kind of have a higher level of collaboration with outreach and our partners, we worked through a process and established the Anchorage Multidisciplinary Outreach Team, commonly referred to as AMDOT. That was kind of an idea that got driven and then kind of went into fruition over the last couple of months, and it's been working out really well so far. Little bumps and bruises along the way, but overall, I think it's doing really well. They have a daily huddle in the morning, and there's sometimes 20, 25 partners on that daily huddle. And it's interesting because we're getting a lot of support from providers to be at Beans Cafe during the breakfast meal. And they spend about 2 hours down there interacting with folks that are coming in from the cold. And it's a great opportunity to connect with people directly and do some assessments during their meal time. It's been great working with Scott at Beans and Third Avenue Navigation Center. They've really made this an effort and a priority. And we see that just kind of on some of the things that like with Beans Cafe expanding their operation hours to allow people to come in and get warm. And it gives us additional capacity and capabilities to go in and talk to folks a little bit more. So it's been, like I said, about 2 months. We're working through some legal stuff, but overall it's been a really great process. And it really helps us working with some of our clients that have complex care needs. And so really able to deconflict in real time on how to get somebody with a complex care need into shelter. And just want to say how great these two ladies are to my left and supporting that effort and working with my team and the other teams. And not only those teams, but just the police department in general. Any patrol officer at any time can call Kathleen or Emily. They know them by name on the street in patrol, and they support us, and we're very thankful for them. The other update I have is that we recently we did a kind of a co-application process with True North Recovery through the Alaska Department of Health and Social Services for a comprehensive opioid stimulant and substance use grant that you guys will see. It'll come to the assembly on the 17th for approval. It's roughly a little under $250,000 through 2027, July of 2027. And what that's going to do operationally is going to give the HOPE team a full-time peer or clinician or a combination of two substance use disorder kind of representative on a full-time basis. So True North Recovery has worked with us in the past for probably the last 5 to 6 months, just coming in and working with us. And they've put quite a few people in treatment. So the concept is real time. We find you in a condition where you're ready to accept treatment, and we are able to take you from the street and put you into a treatment facility. And so True North Recovery will be helping us manage. They'll manage that for us, for the Anchorage Police Department, the HOPE team, AMDOT, whoever we're working with. And they will not only be responsible to kind of manage the in real time, contacts, but they're also going to be in charge for me to go out and partner with our recovery centers across this, across Anchorage and even in the Valley, right? Because we want to get people in treatment. We don't care where that is. And so having the connections with the treatment providers, having the connections so that they know who to pick up and call, whether it's Anchorage Recovery, Clitheroe, whoever. And even when it comes to the stabilization centers where they come online. So that's an exciting thing for us to push out to the assembly for approval on the 17th. And I'm sure if you have any questions, you can let me know and we can go over it. But it's pretty exciting for us. So those are my updates and pending any questions.
I don't see any questions, but I just have one question. Through the MDOT process and just through your outreach in general, I'm wondering about these populations of folks that are harder to connect with, harder to serve, and I'm wondering about the variety of strategies that we have for outreach and variety of options we have for outreach, specifically, those that probably need a different approach. And I guess I'm just curious about what the options are there. I mean, one example would be someone who was fearful of law enforcement. Is there another option for someone else to go out there and try to connect with that person? Can you speak a little bit to the sort of options we have for outreach, knowing that we need different approaches for different folks?
Absolutely. And that's why AMDOT was established, right? Because it's a group of individuals. So it's all not all of them, but it's a majority of the providers in the city all sitting down. And if we have a client that's out there that may have a hesitation to talk to, Ruth or another police officer, there's a team immediately ready to pick up and go out and do that work. Like it's just right then and there. It's real time. And that's what we wanted. So we're not missing anyone. And maybe they don't want to, I don't know why you wouldn't want to talk to these two ladies, but if they don't want to talk to a specific, outreach team, we can just substitute somebody immediately. Or, there could be a client that has a specific need that a specific outreach team can really focus on, and they have that niche and they know how to go out there, talk to that client, and then they can provide that service directly to the client in the field and speed that process up. We now have that capability to coordinate that in the morning and get that team out there. So there's less time waiting when you have outreach folks coordinating specifically to get to the people in the field and deliver the service that they need at the time they most need it.
Yeah. And do you have folks involved in that have lived experience as well? That
Absolutely.
That they're involved
Yeah.
in the network?
Yep, and that we have them in both in the homeless community, lived experience on the team, and then also that's kind of one of the reasons why we have the True North grant is because we wanted a peer, somebody with lived experience, partnering with the police department out there in the field, saying like, hey, we can get you help, and it's been extremely effective.
Great, that's great.
And
Yes.
can I just add,
Oh, sure.
this is Thea. So just to name some of the partners that are coming to the table pretty much every morning. So the Hope team is the convener, like they facilitate. We always have Beans there. We always have RRS. The health department's clinical team is a super active member. So we have 2 physicians as well as their clinical outreach team, which includes nurses and community health workers. We have the VA is very active with us, of course, the coalition. And then we also were kind of feeding back through Lieutenant, sorry, who else? Oh, and Awake. Yeah, Awake's been awesome. Like they now have their outreach folks there too, because they have a whole other set of resources for people who've experienced domestic violence or sexual assault. So it's I think exactly what Lieutenant Fuchs said. There's lots of different players. Oh, and then also community members like Kenny Peterson. He's also bringing in other community members that we haven't been affiliated with before. So it's a really great opportunity. And then of course, Third Avenue Nav and all the people who are already kind of coming into Third Avenue. So it's a really great way of like circling up all the different agencies and outreach folks.
Ms. Baldwin.
Yeah, I'm curious what kind, like, maybe this will come up with the data dashboard question also, but what kind of access do all of these partners have or not have to HMIS?
This is Emily through the chair. It's a combination. For example.
I don't think it's working.
Yeah, that one's not working.
Hello? Okay.
There you go.
Through the chair. We have a combination of providers, and so we have been doing a bit of a dance when it comes to data while we're in the meeting, where the beginning of the meeting is for all providers, and then we stay on for case conferencing for people who are allowed to have access to that information later in the meeting. But not everybody has access to HMIS. So like Awake, for example, Kathleen and I can't access it. We're a cleared CHO, but we don't have direct access. The APD Hope team is working towards having access, but doesn't have it quite yet. But and then the shelter operators do have access. So it's kind of a combination.
Yeah.
And
I'm grappling to imagine, and so yeah, excited to hear the next.
And just so you know, ma'am, it's Lieutenant Fuchs. One of the things we're looking at right now is, through legal, how we can establish maybe a request release of information, which encompasses all the key players, to kind of bridge that gap when it comes to information sharing. So we're taking it like we're attacking it every different stage where we can be successful in providing folks the help they need. It becomes extremely frustrating from somebody that comes from a very strong operational background, where it's like we want to help somebody, but we can't say a word or something, and I just get very frustrated.
Yeah, I can see that being a really challenging thing to navigate when you have a lot of different people collaborating on a project, but not everybody has access to the same information. Not everyone can enter data, which means other operators don't have insight into what's actually happening. I mean, I could see that being a really, really challenging thing to navigate for everybody. And then of course that, begs the question in the community, how do we know that anything that we're pulling from that system is real? So yeah, that is a huge conundrum. And I'm really interested in doing whatever I can to help support and solving that, if anything, from this side of the house. So.
Okay, thanks. Let's move on to the health department.
All right, Kimberly Rash, Anchorage Health Department. So I'm going to be talking about the community health worker and providing an update. So as you, I can kind of go back in history a little bit. So in early 2025, the health department put together a social determinants of health survey in which we surveyed individuals coming into the health department on their needs and what was lacking. And so through that survey results, we realized that we needed a community health worker. In late Q3 of 25, we put an appropriation and plan in front of you all in regards to the opioid settlement funds. And part of that plan included funding at 70% a community health worker. The other 30% is coming from our public health nursing grant, which is a federal pass-through grant to the health department. And we posted that position in late 2025. I'm excited to say that we are hopefully tentatively having an individual start next week. And a little bit of background about the community health workers, that they will work primarily alongside our AHD clinical staff and is also expected to be detailed as an asset to the MDOT team to provide case management and coordination services in conjunction with AHD's outreach team. We expect the position will collaborate closely with external partners such as behavioral health providers, substance use disorder treatment programs, housing and social service agencies, and other community-based organizations as part of a coordinated care and referral pathway. Again, this position is brand new to the department. We've not ever had a position like this before, so this is why it's all contextual right now. The community health worker will focus on community-based outreach, care coordination, harm reduction education, and navigation to medical, behavioral health, and social services, with an emphasis on individuals affected by opioid use disorder and other complex social needs. Over time, the role may expand into deeper partnership development, data collection and reporting, and increase involvement in public health response activities. And so sort of our concept here and what we're hoping to see is if there is a greater need, what can we do in order to increase the capacity within our outreach team to include more community health workers. We anticipate onboarding period to be about 4 to 6 weeks, which will include all of our orientations, policies, procedures, shadowing clinical and administrative staff, training on our outdated electronic health record and reporting requirements. But given the candidate's experience, we expect a shorter period to full productivity. So we're super excited for this position. We're excited to see if we can expand it later in our time here, and then potentially what other funding strings we can pull into that network. Any questions?
One position, that's what we have. We're doing one and then hoping to expand later.
Correct, yes.
I don't see any questions. Thanks for the update. Appreciate it. Okay. Mayor's office, dashboard. Actually, we're gonna take a 2-minute pause. I think we're gonna have a fix of the microphone. So we're gonna have a 2-minute at ease. Is that all right? Okay, and then we'll come back. I think we're gonna have it repaired. So talk among yourselves.
Test. Hello.
Right.
Okay, we're going to come back to order, and we're on our fifth item, homeless and health dashboard update. Mayor's office, if you could introduce yourself for the record and you can begin.
Great, thank you. Thea Agnew-Bemba, and I'm a special assistant to the mayor working on homelessness and health and community safety. So before I get started, I want to just emphasize one word on this slide that says draft. The reason for that is that we are, I mean, as you've heard, we are really trying to build a very integrated system. And in the past, we've tried to get all of the information that I think this committee and the assembly has been looking for really from one source, which is HMIS. And that we have pulled from HMIS into this set of metrics. But I think we've also learned as we've been developing this that's not the only data source, right? So some of this data is coming from other sources as well, and I'll try to be clear about that as I go through. The other thing I think you're all going to say when I share this with you is like, sure, you guys are doing a lot of work, but what's the result? Again, this is where we don't have the system yet to really give you the type of information I think you're most interested in, which is kind of somewhat the longitudinal information, like when a client has this experience, what happens afterwards. Member Baldwin Day has already pointed to, I'll just skip to the punchline here, which is, I think one way to imagine this is, say you were somebody who worked in an emergency department in a hospital and you walked in for your shift and there was maybe 200 people in there and you were like, what's going on with these people? And someone's like, no idea. What's that person's name? Dunno. Like, how long have they been here? No idea. Like, how can I find out? You can't. So that's really what we're doing right now. We are barely even using computers when it comes to actual, like, understanding the needs and information of clients and having any way to share that between our teams. So at the end of this, I will tell you what I'm hoping we can do about that. And it's not that we haven't done anything, we're working on it. But that's where we are right now. So the data that we're sharing today is coming from all these different groups and sources. Therefore, a lot of it is duplicated. So a lot of times you want to know, how many people is this? The reason that answer is so hard to come up with is because we have multiple sources. People are touching the system in different ways, and we can tell you how many times they touch the system in that way, but knowing who they are or what else they did, we don't have that ability yet. So that's why it says draft, but that's what we're working towards. Okay, so success, what does it look like? We really want a safe community for everyone who lives here, including people who are experiencing homelessness, including people who are deep in behavioral health crisis, including our neighbors, kids going to school, everybody. That's our goal. And to get there, when we're specifically talking about people experiencing homelessness, people experiencing other types of health crisis, we really need clear pathways that help people move from crisis into a safer situation. And again, as you've heard today, safety means something different for each one of us. So, so just starting off, you know, I think $1 million question we're always asking, how many people are unhoused or in crisis? This is the point in time count looking back over 6 years. You've seen this before. It really focuses on a subset of the population of people in Anchorage who are experiencing homelessness. So this looks at people who are unsheltered, that's the dark blue, the bottom, people in transitional housing, and people in emergency shelter. And so as you can see over the last 3 years, we haven't made much of a dent. We've kind of been at the same level the last 3 years. And next week, we will be doing our point in time count again here in Anchorage. And, you know, I can tell you all of us really want to see turning the curve this year. We want to see fewer people sleeping outside. Oftentimes, just to state the obvious, the number of people that we count who are in emergency shelter or transitional housing is kind of a function of how many beds we have, because they're usually full. And so that's how many people we usually find in those beds. But the number that's unsheltered, that has clearly gone way up over this period. So we really want to see that number in particular go down. And then, you know, the other ones might stay similar because we still have similar number of beds. This is a separate chart with similar information. Here, what you're seeing is not only the people who are either unsheltered, in transitional housing, or in emergency shelter, but you're also seeing people who are in other types of housing that is counted through HMIS. So for example, people who are in a rapid rehousing program, people in permanent supportive housing, they're also being counted here. So you'll see in the blue, that's the total beds that we have. So you'll see in 2025, it's 2,000, sorry, my eyeballs aren't working very well, 2,818, is that right? Yes. Yeah, okay. And then that orange line is the number of people that were counted in the pit count. So I think this chart is actually kind of interesting for us to look back historically and see that generally we have a little bit of headroom between the number of people being counted, that's the orange line, and the number of beds and housing units that we have, that's the blue box. But you can see back in 2022, we had a lot more headroom than we do right now. So again, we're hoping to always have a system that has enough extra capacity that when people do experience some type of homelessness, they're able to rapidly get that resolved.
Yeah. I have a question for you, Ms. Brawley.
Yeah, thanks. So, and maybe this is on a later slide. I'm curious, because I'm trying to square the numbers, and obviously we know the limitations on the numbers with kind of at least the anecdotal experience that we hear. So I'm curious, of these numbers, we see it is pretty stable, but we know there are folks out there getting evicted, right? There's kind of people entering the system, and then we know there's folks exiting. So how much, I guess, churn are we seeing, especially in the last couple of years? Like, are we seeing a lot of, like, basically, is this the same number of people from beginning to end, or is it a lot of kind of influx and outflux?
I don't know if I can answer that question. I would think, I'm guessing maybe Jessica could think about that a little bit. I think it's a good question. I don't have that in this presentation today. Yeah, okay. But we do have that information. I just would need to pull it together for you.
Okay, yeah, I think that'd be helpful, because I think it's helpful to kind of unpack, like, we know there's a lot of folks who've been out there a long time, and then those are the people that we hear the most frustration from the public about, whatever perceptions they have. And then we also have the reality that we help one person and then someone else is out on the street because we are in a really terrible economic situation right now. And there's just so much uncertainty, right? All of it. And so I think it would be helpful to at least try to understand how much of it is the same person from beginning to end of the year.
Yes, and then actually see the beginning comment about it being a draft, because that's exactly what we can't do very well. We can do that better in HMIS. So I think, like the question you just asked, I think we can answer that question with HMIS. I think with some of the folks that we're trying to resolve that, are in different situations, it's much harder for us to do that.
I just wanted to add, and then Ms. Belvente speak, that concept of inflow and outflow, I don't think for the folks in this room it's new, but I would say that after going to community council meetings and talking to people about it, it was a big aha of, because so often we report it out as one block and then a next block and a next block, there is a perception that the same people are out on the street year after year
Well,
after
some people
year.
are.
Right.
Yeah.
And that is true for some,
Mhm.
but there's a significant percentage of people that move into treatment, move into housing, move out of state,
Mhm.
something else, move out of that, and then people moving in. And I think that concept or that idea or that knowledge is really, really important as we start to create more public awareness around this, and that it's not a static group. And so I just wanted to say that I think sometimes it becomes, well, obviously to this group, but I would say that a lot of the conversations that I have in public, that is not very well understood.
So I think that's another thing that would be helpful as we go through this, to just hear what you would like us to show. But I think what you just articulated is a good measure that we can easily do, which is look at all the people who experienced homelessness in 2025, for example. What was their length of time homeless? So was it over a year, or was it 2 weeks maybe?
Right.
So, and I think we can show you that in bundles, which I think would help you see that.
Yeah, I think my question was going to be along the same lines. I mean, I personally find it encouraging that we have sort of stabilized, right, around like 2,600 people. But I think understanding sort of the breakdown within that population, right? Like those are not 2,600 people who are chronically homeless. Like this is not the same, like this line does not represent the same population of human beings. There's been flow in and flow out. And I think that having that in somehow broken out in a visual way, folks who are chronically unsheltered versus the folks who were unsheltered for 6 months versus 2 weeks, right? I think that would be very helpful to see, to demonstrate that we're creating stability, and then obviously the ultimate goal is for that curve to come back down. And seeing sort of the proportion within each bar would be, I think, helpful for the community to visualize that no, we are not in fact paying for the same 2,600 people to receive shelter, treatment, all of those things. That this is a shifting population.
It's a segment of our community that. Yeah. And I think the thing also just to keep in mind in terms of what part of the group, so there's a whole range of folks that are experiencing homelessness, and our priority of this mayor's administration is really to focus on people who I would say are amongst the hardest to serve, because if we don't serve those individuals well, they will end up at AFD, they will end up involved with the police, and that's what we would like to avoid. And so we've chosen to focus on the goal of fewer people sleeping outside and maintaining a good shelter system, because we want to focus on people who otherwise would be in and out of criminal justice, in and out of emergency departments. There are other people within the group of people experiencing homelessness who our community partners are serving, and while we might help fund some of those things and applaud their efforts, we're not as directly involved with that as we are with the group of people that we're talking about. So I think that's another thing just to keep in mind in terms of like what we're bringing to you most often. It's a group of people within the population of folks who are experiencing homelessness in Anchorage.
Yep.
Okay, so this is just looking at 2025. And again, I'm just trying to give you some kind of global picture of people who are either unhoused or in crisis or both. This is looking at the fire department's count of really opioid related incidents. So in previous years, we've kind of separated out administration of Narcan from transports. And in 2025, the fire department has added a couple of questions and tried to just get a little bit more specific count of these incidents. And so in 2025, we had about 2,000 opioid related incidents, which include transports or times when we administered Narcan. And then in addition to that, the health department distributed over 1,000 Narcan kits at community locations. So I think this is really just to communicate to you that this is still a huge part of our challenge, is addressing and hopefully defeating the scourge of opioids in our community. And that's something we're all working on in different ways. Okay, so how are we addressing this? I'm not going to walk through these two graphics. I think you've seen them many times, but just to remind us that on the one hand, we're really building a safety net, shelter, and kind of crisis response and outreach system. And that's really focused on people who are unhoused and need access to shelter. But again, recognizing that the people that we're really trying to serve also have a lot of other needs and are often also experiencing behavioral health related issues and crises. They're also sometimes experiencing physical disabilities, functional disabilities, cognitive impairment. So there's a lot going on in addition to the fact that they're unsheltered. And some of those things are the reason that they're unsheltered. So we are pairing our safety net and shelter system with our crisis response system. Our crisis response system also serves a lot of people who are housed. And I'm going to give you some of that data in a minute. But just so you know that we're really integrating these together, because again, the people we're trying to serve need some of both. And then we also have a lot of different points of intervention. And this graphic that I'm showing you is actually from Matsu. And I was trying to find a cool graphic to depict this for you. And I was looking at a bunch of different ones. And then I found this one. And I was like, oh, this is actually really good. So maybe I'll create one like this for our system. But really just to walk you through, there's really prevention, which is how do we stop people from being evicted, like Member Brawley was, or Vice Chair Brawley was just speaking to. Diversion sounds like it's the same as prevention, but it's slightly different. That's more when somebody kind of shows up in the system. How do we immediately divert them? So I think like Kathleen and Emily do this a lot where, and Kathleen was just speaking to this, somebody comes up because they're like, ooh, I'm going to make $1 million, working in the gold rush here in Alaska. And then pretty soon they're like, on the street. How can we just get that person diverted out of our system? So how can we get them a plane ticket back to where they came from? Or how can we, come upon somebody and say, oh, you really have a family member who's willing to take you in, like, let's divert you. So that's an immediate diversion. We also do diversion to treatment immediately. So sometimes people will be camping and we can take them immediately to treatment. So they never really come into the rest of the system. So there's lots of different ways we can divert. There's also, of course, our criminal justice diversion programs that we're working on, which is from a different type of context. So the point is we have a contact and we divert. Outreach is a much more proactive thing that we're engaged in. That's where we're really trying to find people and we're trying to engage with them and offer and build trust. And again, you're going to see in here, we can do that many, 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 many times. And that's just what we do. We just keep offering. Crisis response is a whole array of things that are really more focused around an immediate crisis, usually related to behavioral health. Treatment, that's, as we know, there's lots of forms. There can be residential treatment, there can be outpatient plus housing. That's what we're going to be delivering through our micro units. There's even kind of mobile treatment that can be provided. Shelter, I think you're familiar with what we do around shelter, and then what our community partners do. And then housing is really where people can go from that. And then this graphic also has long-term solutions, which I think get at some of the real underlying reasons why we have an increase in homelessness and some of the things that Member Brawley just spoke to around, people being evicted. Why are they being evicted? Well, their wages are not keeping up with their rent. We don't have enough housing, et cetera, et cetera. So that's just like all the different ways we can intervene. Okay, so now into the kind of data. And I'm going to walk through some of those points of intervention here. So first question is, are we preventing people from becoming homeless? So we have a number of different ways that we work on that, both our community partners who record their information in HMIS, and then also the Aging and Disability Resource Center at the Health Department is where if you call 211 and say, I'm worried I'm about to be evicted, they will send you to the ADRC. And that's where we administer federal funds and help people immediately, resolve issues and hopefully prevent their evictions. So 544 households were helped by the ADRC and by our other community partners to prevent eviction in 2025. And all the numbers I'm giving you are all 2025 numbers. And then in addition to that, although could be some of the same households, this is where, just be warned, all these numbers are potentially duplicated unless I'm telling you that they're not. We also helped 717 people with our ERA 2 funds help either get into housing. About half of them moved from homelessness to housing, and about half of them were prevented from becoming homeless through that program in 2025. On the flip side, we had 366 people of the about 1,400 people that had been housed in the last 2 years that were recorded in HMIS return to homelessness. So about a quarter of them. And then when we look at people who are new to shelter or transitional housing, so, and really what the measure is within the last 2 years, had they come into shelter or transitional housing, we had about 2,400 people come in who hadn't been in those locations in the past 2 years.
Yeah. Ms. Brawley.
Yeah, I think that last bullet point, I mean, again, I know this is not to deep dive, but I'm really interested in, again, are those folks who haven't touched the system but have been outside off and on for 10 years, or is it people who have a job and can't pay rent, right? I mean, and I know there's, again, it's not two sets of people, but I think that's really important because 2,400 people is about 1% of our population almost, maybe a little bit under, but I mean, that is a massive number of people. And I think we really need to understand, because if the story truly is, we are seeing a lot of people who had jobs, were stable and are not stable anymore. We really need to know that. And I know that's what you guys are working on, but I think, because again, I think the narrative is there's a bunch of people out there who are doing what they want, are choosing to be outside, and they're all criminals or whatever it is. And we know that that isn't true, but I think also that obscures this other part of the story, which is there's a bunch of people who are already on the margins and we have not been successful in keeping them housed. And so, or they have not been successful. So I want to drill down into that because I think it is super important. And I think it should be a massive alarm bell if we're seeing more evictions, if we're seeing more people living in their cars, all of those things, because that's what's happening in most other cities in America at this point in some way. And so anyway, I think to be able to drill down on that beyond the dashboard, I think is super important. So I'm going to keep underscoring it.
Great. Okay, so this question is, are we reaching people who are in crisis, who are in camps, who are on the street? And it could be one or all of those things. So there's a few different teams that I'm sharing data from in this slide. And I want to first point out that the main graphic is our mobile teams. Only a proportion of the people served by those teams are unhoused, but they're all experiencing some type of crisis, behavioral health related. So in 2025, we had almost 25,000 requests for mobile teams. That's not 25,000 people, that's 25,000 requests. And you can see in here that, about 60% of our calls are answered by the safety patrol. And I'm going to share some more data about them in a little bit. And then our mobile crisis team at the fire department is what you're seeing in that kind of red color. And our mobile intervention team at the police department is in the blue at the bottom. And just a reminder that mobile intervention team is sent to crises where there's a significant safety risk, and mobile crisis team goes to ones where that risk is lower. In addition to that, the HOPE team had just over 3,000 contacts. So that's a team of 2 people. And again, those are not individuals, or they may have seen the same person multiple times, but over 3,000 contacts in 2025. Our community outreach partners, so that's a number of different providers that all record their information in HMIS. They had just over 4,000 contacts. And again, these are duplicated between these. Our clinical team at the health department had over 10,000 contacts, and that's through many, many outreach events that they do throughout the year in lots of different locations. So again, those could also have been people who were housed or unhoused. And then this team right here had almost 2,000 contacts, which is, again, a lot of engagement. So I think the moral of the story here is we are doing a lot of outreach and engagement, trying to make those offers to people in the community. So then how many people is that? So the previous slide was how many contacts. This is about how many individuals are we seeing through those various teams. And right now, the HOPE team doesn't have a way of telling us how many unique individuals. We will be working on that 2026, but we don't have that number for them. But when we look at the fire department's mobile crisis team, in 2025, they served 2,670 individuals. And again, a mix of housed and unhoused. The mobile intervention team saw just over 1,800 people. Our clinical team at the health department, this was only through camp outreach in 2025, 736 people. Our community outreach partners, that's a few different teams, served over 1,000 clients. And then again, RRS, these two over here, served 900 clients. And when I was talking with Kathleen and Emily about their number, the kind of breakdown that they shared with me was about 400 of those are fairly quick resolution. Like you engage, you're able to offer something, you're good. About 500, much harder. So about 500 are more of people who were not able to provide the right service to meet their needs. And it's more of a churn. In this slide, I'm showing you just for those mobile teams, what proportion of their clients are housed versus unhoused. And then some of them we don't know. But for the mobile crisis team, it's about just over 30% of their clients are unhoused. So about 827 clients. And for the mobile intervention team, about 20% are unhoused. So about 365.
Got some questions. Ms. Baldwin, you want to go first?
Sure, thank you. So these numbers, we can assume that there is some kind of Venn diagram of people who are served potentially in all 3 or 4 or 5 of these ways. Do we have a way to disaggregate that?
Or do you mean to aggregate it? I mean, do we have a way of knowing in a
Yes.
client who our clients are?
Yes.
Not yet.
Got it. Okay.
Remember the punchline.
Ms. Brawley, did you have a question?
Yeah, I'm just curious, because I think we have a decent understanding the types of cases that would have mobile crisis team, and we know that they are serving homeless folks and not homeless folks. But for mobile intervention team, what are some of the examples of cases that are not unhoused people? And I recognize APD was here and is not here now. But I'm really just kind of curious because I think again, public perception is like, oh, these folks are taking up all of the resources of both of these teams. And then we know that's not true. And it's interesting how little of the MIT is being utilized for that. So I just want to understand, and maybe that's a follow-up for the Public Safety Committee, but understanding a breakdown or some examples of the folks who are housed who are utilizing that team.
Yeah, so I think, and it would be great to get more information from Lieutenant Pukes and others, but generally what they're responding to are incidents where there is a real safety risk. So they respond to a lot of domestic violence incidents, people who are suicidal and have a weapon and are, in their home, assisted living homes where a person is, their behavior escalates and there's a safety risk. Those are all examples. So yeah, 80% of their clients are people who are housed.
Yeah, I think unpacking that, and again, maybe at the other committee at a future time would be really helpful.
Mm-hmm. I think it's also kind of interesting when you look at this chart that as the mobile crisis team started seeing more people who are unhoused, the mobile intervention team started seeing less. And so I think that's actually an example of us using appropriate resources, because I think I don't want to generalize too much, but generally I would say the people that we're seeing who are unhoused, there's not an imminent safety risk. If there were, we'd have mobile intervention team there, but a lot of it is dealing with the crisis that's occurring. And so we want to reserve the mobile intervention team resource for when there is a safety risk.
Ms. Baldwin.
I have a question on the previous slide, actually, and which is, to what do we attribute the increased utilization of MCT and MIT? Is that an increase in utilization because we had more capacity with the MCT to respond to more calls? Are there just more calls?
Yeah, the increase in MCT is because this year we did a pilot project to do outreach and we added a second MCT team. And then after the pilot project ended, we kind of kept going with outreach, right? I mean, we just kept going with
The simplest answer is it's hours in service. So we've expanded MCT to 7 days a week and 24 hours a day. And we had an additional MCT2 unit in service more from 5 days a week, 12 hours a day.
And then MIT also, most of that increase you see from 2023 to 2025 is just that we added teams. Yeah.
Just a time check. We want to make sure we have some time for audience
Oh, shoot,
participation.
we're way over
Yeah,
already.
it's okay.
Should we just stop and do the
Well,
rest later?
Do you want to provide some final thoughts? I mean, I know you have quite a few slides left. but-
I think we should just be intermission and then do the rest later because there's a lot more.
Yeah.
I'm sorry, I was supposed to
Oh,
keep myself
no,
on
it's
track
okay.
and I
It's
totally
okay.
didn't.
Well, we asked lots of questions. We asked lots of questions
Yeah.
too. So, but any final sort of words you want to share as we?
I
as we
think
wrap
just
it up?
two things. One, we are going to be vigorously addressing the shared information challenge. That's one of the things that we'll be including in one of our proposals to the rural health transformation project through the state, is to basically start using computers and information to help us both coordinate care, get the data that we need, and then kind of lay the groundwork so that we can bill for services, so we can really sustain the work that we're doing. Because right now, and then just one other thing that's not related to this presentation, health department has been vigorously trying to get the contract completed for the operator for the micro units. And we're this close. So it may be, and of course this is, leadership can make the final call, but we may want to lay it on the table for you at the next meeting. Actually, we can't do it at the next meeting because it has to be 7 days after we have the intent to award. So it's basically as soon as we are able to, we're going to bring it to you. So probably means maybe at this point, are we on the addendum for February 3rd? Yeah, so it's going to come to you as quickly as we can get it to you, basically. Yeah.
Thanks very much. Thanks for the work you all do. Really appreciate the presentations today and the information. Thank you. Okay, in the last few minutes, I know we have at least one person. Do we have anybody else who wants to share some thoughts? Yes. So you have two folks. Anybody else? Okay. All right. So this is how it works. We'll set up a microphone over there. Travis, if we can set up a microphone in the chair, that would be great. And we'll set up the clock. Each person will have 3 minutes to testify, and we'll get going. Okay, let's, whoever would like to come first, come on up. Please share your name for the record, and you'll have 3 minutes.
Hi, my name is Nithya Thiru. I'm a resident of East Anchorage, and today I'm actually testifying on behalf of a friend who is a nurse at ANMC. She was not able to attend today. She's working, so I'm just going to read a statement from her. I am a med-surg nurse at ANMC. I couldn't be here today because I am at work, which has felt very heavy this season. I am testifying because I want to bring attention to the irreversible harm from cold injuries done to unhoused people in Anchorage this year. Nearly every shift I've worked over the past 2 months, I've taken care of a new patient who has been admitted to the hospital with severe frostbite. Since frostbite patients tend to stay in the hospital for a long time and require help with mobility and wound care performed multiple times a day, I've gotten to know many fairly well. It can take weeks for the wounds to demarcate before we know what tissue can be saved and how much has to be amputated. It's hard to watch a patient come to terms with losing their limbs. Some people lose a few toes or fingers and do okay. Some lose half of their foot, which significantly affects their ability to walk. Sometimes frostbite wounds become infected, which leads to serial surgeries that drag on for years. Some people have bilateral below-the-knee amputations and become wheelchair-bound, due for a lifetime of pain and compounding health complications. You see, none of these ordeals earn a person stable housing. Ask a discharge care coordinator what it was like when all shelters, even the cold weather shelters, were full a few weeks ago. Stable shelter is the biggest barrier to discharge for our frostbite patients. Imagine how scary it must be knowing that even if you have a shelter bed today, it's not guaranteed tomorrow, and wondering how you're going to navigate the sidewalks and bus system with your new life-altering injuries. I'm not an ER nurse, but you could ask one what it's like to do CPR until somebody's body temperature comes up to 90 degrees because a hypothermic patient can't be pronounced dead until they're warm. This is also happening this winter. This is highly preventable, but you need to understand that there isn't any margin for error here. It only takes a single cold night outside for someone's life to end or change forever. This is Alaska. Every year, winter is cold. We know this, and yet we are reactive instead of proactive about this public health problem, and it is too little too late. Please explain to me, because I haven't heard, what is the plan here? What is this committee doing right now to reduce cold injury and deaths for unhoused Anchorage residents for the next 3 months? What will the municipality do differently next year? On behalf of my patients, please answer and please do something. Thank you. And just wanted to add that I am happy to arrange any kind of meeting with healthcare workers. It seems like just from hearing the meeting today that there is interest from the body to know a little bit more about what's happening with turnaways. And it seems like healthcare workers might be able to fill in some of those gaps about what's happening on their end and what they're seeing. And I think that might paint a very different picture than what we're hearing from what we heard today from folks.
Thanks. Thanks very much for your this. Okay. Come on up. Share your name for the record. You have 3 minutes.
Okay, question first for the chair. As the self-anointed head of the Anchorage Homeless Community Council, can I get 5 minutes, sir?
No,
That's
you have three minutes.
All right. So Jamie Lopez, East Anchorage, formerly Coalition, formerly Homeless. So yeah, the land of make believe. I'm watching this play out monthly, and more or less, you know, you have a team of individuals that go ahead and assemble, but really, it's not the Avengers. It's sort of the coalition of the willing, and a lot of people are based on basing their participation based on the fact they all want to get money, or they do want to help people, but it's sort of along those lines. And so anyways, if you look at the Anchorage Police Department camping ordinance dashboard, basically what you have is 54 arrests, 335 have voluntarily complied, and 29 have accepted services. Again, less than 7%. ACH data dashboard as of December, basically have 225 that are new, return from housing 57, return from inactive 163. And then at 90 days from that latest report, only 110 got housed and 410 are inactive. They have no idea where they've gone. And so change is possible, but you know, people have to be willing to listen. And so the simple fact of the matter is, there are any number of people in this room, they do not have lived experience and they're making decisions. And while they're good in offices and doing PowerPoints, they don't go outside and they don't interact with people daily. And when you talk about outreach, you know, you said, okay, Lieutenant Fuchs, give us an update. All right, it's a law enforcement operation. And they're attacking all of these things onto law enforcement. And so it's, you know, Dia basically says, oh, we just have one police department member on here. It's human intelligence, and then they mask it with all these things. And people are not dumb outside. And so they naturally, they've been pushed and pushed and pushed again, and they just don't want to interact with police. And so they will not accept services, and then people suffer for it. So I've come to 19 of these meetings, and basically I haven't seen a change. Nobody's coming to me asking me questions. nobody's coming to me saying, how can we actually improve the outreach conditions? And we're willing to pay for it, but you're willing to pay 150 grand for a police officer to go outside. And so it's sad. So looking at the presentation, so slide 2 and slide 3, it said total in-house. But again, that is based on the people that interact with the system. And so you truly don't know how many people are outside, and you can't put a confidence interval on this thing unless you have people that are not a threat to people outside. They're jumping in and out of houses. The crisis call center thing, it's based on a crisis response on that slide 5. So that basically means somebody's got to have a phone to basically interact with somebody, unless it's the Hope team. And if they're interacting or not, you're probably not getting any idea of what's going on. Slide 7, ERA2, that ended September 30th. So how many of those people are back outside based on presented that data? Slide 8, you basically need a codex to sort of detangle that thing, and it includes housed and in-house people. It's not deduped. Anyways, I could go on. So a little bit of a hot mess today, but I've tried. And so it doesn't look like anybody wants to change. Thank you.
Thanks for your testimony. Would anybody else like to testify at this time? Okay, seeing none, thanks for being here, everybody. This meeting is adjourned.